Dear colleagues, my name is Adrienn Kovács, and I would like to present my 9-month progress from the field of ketosis-prone type 2 diabetes. This type of diabetes is defined by unprovoked ketosis onset with preserved insulin secretion and with the lack of autoimmunity. There is no doubt that during the acute ketotic phase of the disease, patients require insulin treatment. But in the long term, in a significant number of cases, multiplied daily insulin injections are not needed. My vision is that unnecessary insulin administration must be decreased in ketosis-prone type 2 diabetes, and this leads to my mission, which is to increase awareness about ketosis-prone type 2 diabetes and to improve its management. I have two specific goals, two projects. The first is investigating the prevalence and the clinical characteristics of ketosis-prone type 2 diabetes. And the second one is a long-term follow-up study of Hungarian patients presenting with new-onset diabetes with ketosis. Let me start with the first project. Here you can see the status of the manuscript. The results are now finalized, and we are working on the manuscript. We are planning to submit the manuscript to the Journal of the American Diabetes Association, the Diabetes Care. Ketosis-prone type 2 diabetes was introduced by the WHO in 2019 as a hybrid form of diabetes. It has been estimated to account for 20 to 50% of the diabetic ketoacidosis diagnosis in Afro-American and Hispanic patients. We have evidence now that insulin can be discontinued in 75% of the patients after the acute treatment. On the other hand, we have very limited data from the Caucasian ethnicity. Our aim with this first study is to assess the prevalence and to describe the clinical characteristics of ketosis-prone type 2 diabetes among patients presenting with new-onset diabetes with ketosis. Our questions are investigated with the COCO-POP and the PECO frame. And our hypothesis is that a definite number of patients with ketosis-prone type 2 diabetes do not need long-term multiplied daily insulin injections. A systematic search was conducted from about 17,000 articles. In the end, we selected 10 articles to be eligible for the meta-analysis. You can also see our simplified search key here. Let me present the finalized results. Here you can see the prevalence of ketosis-prone type 2 diabetes, which accounts for about 1/3 of newly diagnosed diabetic ketoacidosis or ketosis cases. And since ketosis onset is a typical characteristic for type 1 diabetes, we chose this group as a comparator group. So from now on, you can see the results in comparison with type 1 diabetes. We have found that patients with ketosis-prone type 2 diabetes are older by almost 12 years on average, and they have a much larger BMI. We believe these characteristics will help clinicians identify ketosis-prone type 2 diabetes. In summary, the strength of our study is that this is the first one to quantitatively address the question of prevalence of ketosis-prone type 2 diabetes among diabetic ketoacidosis and ketosis cases. And we used a robust methodology following the instruction of the Cochrane collaboration and the PRISMA 2020 statement. On the other hand, there are some limitations. there was a high heterogeneity among the results of the enrolled studies, and there was a low overall number of participants in the eligible articles. And also the study design was observational in most cases. All in all, we can state that about 1/3 of diabetic ketoacidosis or ketosis at diabetes onset is caused by ketosis-prone type 2 diabetes. And these patients are older and have a higher BMI in comparison with type 1 diabetes. We believe C-peptide and islet autoantibody measurement should be part of the diagnostic approach in every new onset diabetic ketosis case. If you remember, our hypothesis was that in a significant number of cases, long-term insulin treatment is not needed. However, we could not answer this question due to lack of data available. So long-term follow-up studies are also needed to assess the appropriate long-term treatment in ketosis-prone type 2 diabetes. Let me go on with the second project. This is a long-term follow-up study of Hungarian patients presenting with new onset diabetes with ketosis. As I earlier mentioned, we have very limited data available in the literature from Caucasian ethnicity. And our center is the first to present data on ketosis-prone type 2 diabetes in Hungary. The aims of this study are to describe the prevalence of ketosis-prone type 2 diabetes among Caucasian patients presenting with ketosis at onset. And we would also like to compare this entity to immune-mediated adult-onset type 1 and non-ketotic type 2 diabetes. Here you can see our study design. So from almost 200 new onset diabetes cases, based on the presence of ketosis, the presence of autoimmune markers, and beta cell function, we categorized the patients into three groups. The first one was type 1 diabetes with autoimmunity positivity, with the lack of insulin secretion and with the presence of ketosis. The second group was type 2 diabetes with the lack of autoimmune markers, but with preserved beta cell function and with the lack of ketosis. And the third group comprised patients with ketosis-prone type 2 diabetes, which is again characterized by autoimmune negativity with preserved insulin secretion, preserved beta cell function, and with the presence of ketosis. Now we are working on a decision tree model, which based on two variables, the C-peptide, which is marker of the endogenous insulin secretion, and the BMI. We believe this decision tree model will help clinicians easily identify ketosis-prone type 2 diabetes at the disease onset. All in all, the strength of this study is this is a study in Caucasian population, and it reports a relatively high number of patients with ketosis-prone type 2 diabetes. On the other hand, it was a retrospective data collection used, and the results come from only one center, and we were able to use only two types of autoantibodies. I would like to close my presentation with a quote, which says, "Absence of evidence is not evidence of absence." Thank you for your kind attention.